Hello, this is Dr. Rochelle Nakre presenting a multimodal imaging approach to giant right coronary artery to coronary sinus fistulas by Dr. Rochelle Nakre, Anwar Khan, David Gorolov, and Dr. Prasad Chalasani with HCA Longwood Regional Medical Center and Florida State University College of Medicine. Introduction. Coronary artery fistulas are rare, anomalous connections to either cardiac vessels or to heart chambers. These fistulas may be congenital or acquired in etiology. The most common coronary artery fistulas arise from the right coronary artery, accounting for 50 to 55% of CAF cases, and the left anterior descending artery. Coronary artery fistulas make up 0.8% of all coronary anomalies, with an incidence of only 0.002% in the general population. The low-pressure right-sided structures of the heart predispose CAFs to drain there more compared to the left side of the heart. Literature has described the drainage of right coronary artery fistulas into the right atrium, right ventricle, left atrium, coronary sinus, pulmonary artery, right and left pulmonary arteries, and the superior and inferior vena cavas. Clinically, detecting coronary artery fistulas is important because they can present with or lead to an increased risk of heart failure, arrhythmias, infective endocarditis, myocardial ischemia, rupture, aneurysms, and other complications. Coronary angiography and coronary computerized tomography angiography, CTA, are highly effective modalities for the diagnosis of coronary artery fistulas. The standard treatment for coronary artery fistulas is catheterized closure. In this report, we explore other possibilities of RCA fistula drainage pathways due to the difficulty of finding a drainage source in our patient's case. Case report. A 70-year-old female with a past cardiac history of hypertension, hyperlipidemia, obesity, and type 2 diabetes presented to the emergency department with episodic substernal chest pain for the past week. She states the episodes have no triggers, no associated symptoms, and typically resolve within 15 minutes of onset. On the morning of admission, the patient had an unprovoked episode with associated shortness of breath, chest tightness, and pain in her left arm. The patient is at high cardiac risk based on the comorbidities and has smoked 2 packs per day for 50 years. The troponins were positive, and a working diagnosis of acute non-ST segment elevation myocardial infarction was made. The patient underwent cardiac catheterization the same day, and supplemental CTA imaging was performed to better visualize the diseased heart. The results are shown in Figure 1. Cardiac catheterization showed complex left coronary artery disease, image A. A stent was placed in the diseased LCA. Images B through G and video 1 show severe aneurysmal dilation of the RCA that drains to an unclear location. There was no step-up differential noted in the coronary angiography. The drainage of the fistula was determined to be the coronary sinus based on the anatomy and proximity. Discussion. CAFs are rare anomalies in the cardiovascular circulation that form between a blood vessel and another blood vessel, or a blood vessel and a heart chamber. Although rare in presentation, there have been several documented instances of fistulas that arise from the RCA. In fact, approximately half of all CAF literature describes a fistula that is born from the RCA, possibly due to the lower pressures that the right heart is subjected to in comparison to the left heart. Usually, CAFs are found incidentally through imaging, the most effective imaging being coronary angiography and coronary computerized tomography angiography. Conclusion. Clinicians should keep CAFs high on their list of differentials for patients who present with chest pain. While many of these fistulas are asymptomatic and do not need to be treated, symptomatic CAFs can cause hemodynamic consequences such as heart failure, arrhythmias, angina, or myocardial infarction. We urge physicians to have a high index of suspicion for CAFs and explore the option of catheterized closure if a CAF is large or symptomatic. Prior literature is unclear about the patient outcome for catheterized closure, but patients that undergo this procedure must be followed up with closely on an outpatient basis. Thank you very much for your consideration.